Good evening and welcome. Welcome to tonight's Immunisation Coalition webinar. Our topic this evening is meningococcal disease, a 2026 update. I'm Andrew Baird. I'm a GP in St Kilda, Melbourne. I'll be moderating this evening's webinar. I would like to acknowledge the traditional custodians of the various lands on which we work today and welcome all Aboriginal and Torres Strait Islander people that are participating in the webinar. I pay my respects to elders past, present and emerging. I celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Presenting this evening's webinar is Professor Jim Buttery, who will be speaking for around 40 minutes. This will leave us plenty of time for your questions and your comments. We'll try and get through as many questions as possible before the webinar ends at 7 o'clock. At any time, please type your questions in using the Q&A button at the bottom of your screen. This presentation will be recorded. All participants will be on mute for the webinar. We have over 600 registrations for the webinar, so we're expecting a good turnout this evening. You can see Professor Buttery's full biography on the slide on the Immunisation Coalition website or on the University of Melbourne website. By way of a summary, Professor Jim Buttery is the inaugural Professor of Child Health Informatics at the University of Melbourne. He is the Chief Research Information Officer in Infectious Diseases at the Royal Children's Hospital in Melbourne. Professor Buttery is the Head of Epidemiology and Signal Detection at Surveillance of Adverse Events Following Vaccination in the Community. He is Group Head, Health Informatics at the Murdoch Children's Institute and Co-Director of the Global Vaccine Data Network. Professor Buttery also leads an epi-informatics team of epidemiologists, data analysts, and statisticians whose research revolves around the innovative use of real-world data to answer important questions in infectious diseases, epidemiology, and vaccine safety and effectiveness. So a very warm welcome, Jim, and over to you.
Thanks very much, Andrew, and good evening. I'll just share my slides and just confirm they're projecting okay.
Yes, Jim.
Great. Thanks very much. And thanks very much for that warm welcome. So meningococcal disease continues to bother us in 2026, despite many innovations in both science and policy. So today I'll take you through the epidemiology of invasive meningococcal disease in Australia and elsewhere, identify the serotypes that cause invasive meningococcal disease and the presentation trends, describe who's free for eligible for meningococcal ACWY vaccine as well as meningococcal B vaccine on the NIP schedule, and then review recent reimbursement changes around MenB for 3 states, South Australia, Queensland, and most recently Northern Territory. And then if we get time at the end, we can discuss the potential impact on invasive meningococcal disease rates if other states implemented a free vaccination program. So, meningococcal disease is a rare but serious invasive bacterial disease. It's had a case fatality rate of between 5 and 10% that really hasn't shifted despite all of our innovations in care of the seriously unwell patient with meningococcal sepsis. It's caused by the bacteria Neisseria meningitidis, which is a ubiquitous organism. In other words, infection is common, disease is rare, but disease is severe. Globally, 5 serogroups cause almost all invasive meningococcal disease, A, B, C, W, and Y. And recently in Africa, there's been emergence of serogroup X. In Australia, 3 serogroups cause a majority of invasive meningococcal disease, overwhelmingly B as well as W and Y. And MenB continues to be the dominant strain in Australia. So meningococcal Neisseria meningitidis' natural home like the other two meningitis pathogens of childhood, Haemophilus influenzae and Streptococcus pneumonia, is in the nasopharynx. It attaches to the nasopharyngeal cells, and colonization is common. It's usually transient. It's increased in adolescence, but it can occur at any stage during your life. And the vast majority of infections are completely asymptomatic, and the bug goes away without causing any harm. So, as I said, carriage can vary from days to months, and at any one given time, about 10% of the general population are carrying this bug asymptomatically. But the rates may be higher, especially in older adolescents and young adults. We assume due to a combination of both crowding as well as their tendency to swap nasopharyngeal secretions more frequently. And we think that asymptomatic carriers, rather than people with disease, are the major source of transmission of pathogenic Neisseria meningitidis strains. It's transmitted by respiratory droplets or throat secretions during either direct or prolonged contact in the same room. As I've already touched on, although rare, meningococcal disease can be deadly and devastating. Even with the appropriate early recognition and antibiotic treatment, the mortality rate of 5 to 10% has remained stubbornly stable over a number of decades now. Approximately 10 to 30% of survivors have long-term sequelae, and these can be the graphic associations that you're familiar with from photos, including limb amputation, deformity, skin scarring, as well as sequelae from meningitis, including deafness and neurological defects. And in terms of the clinical pathway of meningococcus, it's classically difficult to recognize early. So early on, it can appear as many viral illnesses do: fever, drowsiness, nausea or vomiting, irritability, poor appetite or feeding, often noticed in babies, but as with many other infective conditions. And then clinical features in 20 to 50% include general aches, especially in the large muscles, headache, leg pain, and then you can get also sore throat or coryza. And then as the disease progresses, in less than a fifth, you can get further changes at 8 to 12 hours of cold hands and feet. You can begin to get changes in skin color, breathing difficulty, thirst, diarrhea. And then it's in the latter half of the 24 hours that you start to see, if you like, the classic features of meningococcal disease, where you can get that non-blanching purpuric rash that can extend to a hemorrhagic rash. You can get confusion, delirium, classic signs of meningitis in terms of neck pain, neck stiffness, and photophobia. And then in less than a fifth, you can get more dramatic neurological signs, including floppy muscle tone, unconsciousness, seizures, or signs of raised intracranial pressure in babies with a bulging fontanelle. Alan Jung, who was probably to date the finest infectious disease diagnostician Australia has ever seen, who's sadly passed away now, over 20 years ago wrote this clinical practice paper in the Medical Journal of Australia. And I encourage you that for those of you who may see potentially early meningococcal disease, either in general practice or emergency departments, to go and look up this article. It's beautifully written for a condition that's very hard to diagnose early in its clinical course. So the invasive meningococcal disease typically presents with either septicemia or meningitis or both. And interestingly, the mortality rate is higher with septicemia than it is with meningitis. And then you can get atypical presentations that can occur by themselves or in conjunction with septicemia, including pneumonia, septic arthritis, pericarditis, GI symptoms, and rarely ocular disease as well. And we're all familiar with the dramatic sequelae of severe meningococcal disease, and that can include amputations, children desperately ill, requiring cardiac surgery for pericarditis. And on top of the acute event, in terms of the impact of scarring and especially the plastic surgery required, it can even successful recovery from severe disease can require extensive ongoing hospitalizations and surgery. So as I said, the outcome is 5 to 10%. Meningococcal B, the outcome is slightly better than meningococcal W, at least in this data from 2016, 2017. And as I said, the long-term sequelae 10 to 20 or 10 to 30%. And they can carry a significant burden for many years. That includes scarring, neurological deficits, either partial or full amputation of limbs in up to about 1 in 60, and deafness in just under 1%. And the long-term impacts have recently been established in Australia in a long-term study led by Helen Marshall in South Australia. So what is MenB? So MenB is one of the encapsulated bacteria that cause early childhood meningitis that we've gradually been developing vaccines for. So the classic meningitis triad were Haemophilus influenzae type B, for which we introduced vaccines for in the early 1990s, and essentially saw Haemophilus influenzae type B, meningitis and sepsis become an incredibly rare condition. That was followed by meningococcal group C, and then pneumococcal vaccine round about the same time, both of which have been extremely successful. And the way we've developed vaccines for those is we've taken the capsular polysaccharide outside the organism, or the sugar on the outside of these bugs, glued it to a protein covalently, and been able to trick the baby's immune system into treating the covalently bound one like a protein which babies' immune systems respond well to, as opposed to sugars, which that part of their immune system doesn't develop properly until 2 years of age. So using these conjugate vaccines, we've been able to conquer most of the meningitis bugs. Unfortunately for MenB, that sugar on the outside of MenB is very closely related to a sugar that's naturally found in developing human tissue. And using that sugar doesn't work when we try and make it into a vaccine. So as a result, what has happened is they've had to develop vaccines using proteins that are more variably expressed on the bug surface, and that includes NADA, NHBA, FHBP, as well as outer membrane vesicles that go to make up the 4 components used in the Bexsero vaccine. So all of these 3, if you like, meningitis vaccines have a typical pattern in early childhood of when they cause the most disease. So all of us get protection from our mothers through the placenta when we're first born, and that typically protects us for about the first 6 months of life. And as you can see in the inset graph on this, all 3 bugs historically peak round about 6 months, but cause significant increased rates of disease in the first 24 months of life until our immune systems become more mature and begin to mount response against the sugars on the outside of these bugs. Meningococcal disease certainly shows this age pattern with the highest risks, as you can see, in very early childhood up to the age of about 4. But then, unlike those other 2 bugs, there's this second smaller spike in the 12 to 18-year-old and to a lesser extent 19 to 25, so adolescents and young adults, which we think, as I said, is associated with increased transmission of meningococcal strains from the nasopharynx. And so the risk factors for meningococcal disease include, as we've already discussed, the infant's immune system with waning maternal antibody and their impaired ability to have a mount an immune response against sugars, as well as prematurity. There are folk who have impaired immune systems that render them particularly at risk of meningococcal disease, and these include people with asplenia, especially people with some types of complement deficiency, humoral, or in other words, antibody deficiencies, as well as people with HIV or AIDS. Anything that irritates where the bugs live can also increase the risk of invasive disease, and that includes smoking or a concomitant respiratory tract infection. And then finally, and possibly just as importantly, is social factors, including crowding or close contact with a case, although, as I've said, most new cases of disease come from asymptomatic contact, not from contact with a known case of disease. Multiple kissing contacts, which was a unique study done by a Melbourne paediatrician when she was in London, where she was able to establish that French kissing was an independent risk factor for invasive meningococcal disease, as well as attendances in crowded places such as pubs, discos, and certainly crowded housing arrangements, including military barracks and college dorms. And the reason we know this is that most of our understanding about meningococcal immunology and the creation of the first vaccine actually came from the Vietnam War, where they noted that boot camps had an unexpectedly and amazingly high rate of invasive meningococcal disease. And it was at Fort Dix in New Jersey where Gottschalk, Artenstein, and Goldschneider conducted the classic experiment where they bled 300 troops at the start of boot camp and at the end of boot camp, and worked out what the difference was between those who got meningococcal disease and those who didn't. And they found that having serum bactericidal activity against the capsular polysaccharide of meningococcal C, which was the bug-causing disease at the time, was the single factor that gave you protection. So we also know that episodes of large crowding, such as the Hajj pilgrimage in Mecca, are also significant risk factors due to crowding. And we also know that other areas that can be associated with it, especially due to crowding, include some childcare settings, major international events where there's crowding, refugee camps. I've already talked about military camps, as well as crowded workplaces. And obviously, microbiology laboratories are an independent risk factor. So what about the epidemiology in Australia? So we introduced meningococcal C vaccine in 2003, where, as you can see from that top red line, that was the dominant organism in Australia at the time. And there's been a steady reduction ever since that introduction. Actually, take it back. The middle line is MenC, the top line is MenB. And what we saw is a rapid reduction of group C meningococcus, while group B meningococcus remained relatively stable, has drifted down over the years prior to the introduction of any MenB vaccination. Then in the mid-teens, with the two lighter green lines, you can see we started seeing cases of group W and group Y disease, not just in the pediatric population, but also in the older age groups, which led to the introduction of the quadrivalent ACWY vaccine in the NIP in 2018, followed by the adolescent vaccination in 2019. And then in 2020, for specific at-risk individuals, we introduced into the NIP the Group B meningococcal vaccine. And what you can see here is that at every age group, Group B is the dominant serogroup that we see. But as you go up the age spectrum, especially in the adults 25 to 44, the proportion that's caused by W and Y increases. But even then, B still remains dominant. In terms of notification rates, the period with the highest notification for Group B is disturbingly 3 to 6 months, and then followed by 3 to 11 months of age. But even 0 to 2 months, there's still a reasonably high rate of vaccination. And this was unlike Group C when we introduced the vaccine in 2003, where the majority of cases occurred after 12 months of age, which meant we were able to introduce a vaccine as a single dose at 12 months. And so these are invasive meningococcal disease notifications for Australia last year. And as you can see, although it varies a little bit from state to state, in every state, Group B is the dominant serogroup, with bits and pieces of serogroup W and Y, and varying degrees of serogroups that are not groupable based on their capsular polysaccharide. So in Victoria, this is a gorgeously curated, handwritten chart of meningococcal epidemiology that was curated by Kath Taylor, who used to work in the Victorian Department of Health. And what you can see, if you can read the x-axis along the bottom, it illustrates the classical association with major troop mobilizations with that massive spike that corresponds with World War II, a slightly lower one that we think corresponds with the Korean conflict, and then less dominant ones associated with Vietnam over that time period from 1936 to 1988. And then, courtesy of Lucinda Franklin, that was then transferred into electronic form, where you can see those peaks more rapidly. And then the rate of in meningococcal disease was relatively low for a prolonged period, and then for reasons we don't understand, started climbing in the 1990s, which led to the implementation first of the Group C vaccine and then the other vaccines subsequently. So in terms of meningococcal disease in Victoria, you can see leading up to the implementation of MenC vaccine in 2003, Group C was the dominant organism in Victoria with a decent amount of Group W and also Group B. And subsequent to that implementation, Group B has very much been the dominant organism since then, with bits and pieces of Group W and then more recently Group Y. And this is a more recent illustration and slides courtesy of Janet Strawn from the Department of Health Victoria, who sent me these slides today, even though it was her day off, so for which I'm very grateful. So with the implementation of the quadrivalent vaccine in 2017, we saw a significant reduction in disease in Victoria, particularly for Group W and to a less extent decreasing Group Y, with Group B staying relatively stable in its numbers. And then if you look by 5-year age groups, you can see the variation with Group B dominant at pretty much all age groups, but the older you get, the more variation there is in terms of W and Y. So in summary, in Australia, Group B causes most disease, with W and Y causing almost all of it to make up the difference. And MenB incident rates peak early in infancy, before 12 months of age, followed by children aged 1 to 4, and then that secondary spike in adolescents, 15 to 19 years of age. So globally, what do we see? Well, we know that the meningitis belt in sub-Saharan Africa historically caused outbreaks every 5 to 12 years until the fantastic innovation of the Menafrivac vaccine, which originally just included a conjugate vaccine against the meningococcal group A, and subsequently has been expanded to include CWY and now X. And what we can see is that a scourge that caused a massive number of cases every 5 to 12 years has now been massively attenuated, and the low number of cases has largely continued with the successful implementation of that program. So in association with this, the global number of cases on the left and deaths on the right, you can see has been massively decreased compared to other diseases for meningococcus, which is that second bar with the red arrows. Oh, sorry. So this is number of cases on the first slide. This is cases, and this is deaths. And as you can see, both a massive number of decreasing cases, but an even more impressive decrease in the number of deaths across all age groups. So in terms of Which serogroups cause disease? Well, pretty much worldwide, with some notable exceptions. Group B is the most important serogroup, with the exception for that being in Africa, as I mentioned, where historically serogroup A and serogroup C were the dominant serogroups. And then, as I mentioned, in more recent years, serogroup X emerged and was included in the Menafrivac vaccine. But also in South America, there's more diversity seen as well. In Europe, it's pretty similar, except an interesting pattern with variation between the north and the south, with the south demonstrating what we would sort of almost view as relatively typical serogroup patterns with a dominance of B. And the further you go north, the more variation there is in meningococcal serogroups. So what about our closest region, Asia? Again, as you can see, it seems to be a bit of a north-south variation, with Group B dominating in most of the Southern Asian settings and some of the North Asian settings being more variability with either C or Y dominating. Although China's seen a rapid increase in B post-2015, and they do have immunisation programs for the other serogroups. And then we got COVID. So what impact did the fact that no one was mixing anymore have on meningococcal disease? Well, this is data from England, but it would look very similar for Australia as well. When we had social controls over people meeting each other, we saw a massive reduction in meningococcal disease, presumably as a reflection for a massive reduction in asymptomatic infection as well. Unfortunately, despite that, since those lockdown precautions have obviously been eased and we've returned back to mixing, we've seen a resurgence in meningococcal disease, particularly in Group B meningococcal disease. And these are data up to last year from the Public Health England. So, what are the recommendations? If there are no medical risk factors, you receive, the number of doses vary, but for 6 weeks to 23 months, you get a single dose of meningococcal A, C, W, and Y at 12 months of age, and then again in adolescence. For MenB vaccine, it's not included in the NIP unless you're a specific risk factor, including Aboriginal and Torres Strait Islander, who do receive an infant program of MenB, which is 2 doses in the first 12 months of life and then a dose at 12 months. Then if you're in the medical risk groups, you receive further doses at 2 to 4, or if it's the first time, 2 to 4 years, at 5 to 14, and then 15 to 19. Whereas for those who are not in specific risk groups, MenB is not on the NIP, but you can get it as a part of a private vaccination scripts. In the NIP, the quadrivalent ACWY vaccine at 12 months, and then again at 15 to 19 years. And so this is just the same in more detail, including those for special risk and noting those including laboratory workers as well. So what are the meningococcal vaccine recommendations in the immunisation handbook? So MenB and MenACWY is recommended for all infants and children under the 2 years of age, noting that's not funded under the NIP, although is in some states. It's recommended for healthy adolescents, 15 to 19 years. For both of those infants and adolescents, ACWY is funded, but not MenB, except in the specific states. Handbook also recommended for adolescents and young adults living in close quarters or current smokers, Aboriginal and Torres Strait Islander peoples aged 2 months to 19 years, people with underlying medical conditions that increase their risk of invasive disease, as well as microbiology laboratory personnel. and a quadrivalent vaccine alone is recommended for healthy travellers going to areas where invasive meningococcal disease is more common, such as visiting the Hajj or to mass gatherings. But there's no single vaccine that covers all bacterial serogroups. So what's the difference between the NIP and the state programs? The ACWY is funded from the NIP from 12 months of age. You can get private prescription from 6 weeks of age. For MenB, the NIP funds people with the specified medical risk conditions, as well as Aboriginal or Torres Strait Islander infants from 2 months of age onward, as well as a catch-up programs for Aboriginal and Torres Strait Islander children under 2 years. The specific state programs in South Australia provides MenB vaccine for infants up to 12 months and then adolescents in year 10. Queensland similarly 12 months and then adolescents 15 to 19 years of age with a catch-up program for children 12 months to 2 years that is close to finishing now if it hasn't already finished. And then Northern Territory, who implemented this program in January last year, MenB for infants up to 12 months and year 9 students with a catch-up program for children between 12 months and 2 years of age and adolescents 15 to 19. And again, you can get a private prescription for MenB for other children from 2 months of age onwards. There historically has been 2 meningococcal B vaccines, although only one Bexsero is available in Australia at the moment. So in summary, the handbook recommends MenB vaccination for at-risk groups, including children less than 2 years and adolescents 15 to 19 years of age. MenB vaccines on the NIP for those at-risk individuals, but not for all at-risk groups. And Queensland, South Australia and the Northern Territory are the only jurisdictions that provide state-funded Bexsero for all babies and adolescents. So the currently only MenB vaccine available in Australia is Bexsero, and this is the recommended dosage for that. So 2 doses between 2 and 5 months of age with 2 months between the doses and then another dose in the second year of life from 12 months of age. If you start at 6 months to 11 months, again, same regimen, 2 doses, at least 2 months apart with another dose in the second year of life. If you start second year of life, 12 to 23 months, 2 doses and another dose at least 12 months later. And then children over the age of 2 years, adolescents and adults, get 2 doses more than 1 month apart. And the role for a booster dose beyond these doses that have been talked about has not yet been established. So in terms of safety, Bexsero has been evaluated extensively in more than 13 studies, including 9 randomized controlled trials in over nearly 6,000 infants and children and 250 kids, and just under 3,000 adolescents and adults over 11 years of age. And what we know is in the very young children, systemic symptoms, including fever in particular, as well as irritability, some local reactions, are relatively common compared to the other NIP vaccines. And as a result, there is a recommendation for routine use of paracetamol in the first 24 hours in giving it. On the other hand, despite an increase in fever, irritability, and associated generalized symptoms in the very young babies, there has been no increase in febrile seizures associated with this vaccine in the UK who are using it routinely. In adolescents and adults, very common adverse events include local reactions, injection site pain, in particular swelling, induration, as well as malaise, headache, nausea, and myalgia and arthralgia. There does not appear to be a dose-related increase in the severity or incidence of these adverse reactions as you have further doses. The product information supports co-administration with most routine vaccines, including the hexavalent infant vaccination, pneumococcal vaccine, and MMR, and there does not appear to be any immunological interference. We do know that with co-administration with DTP-containing vaccines, the rate of fever and irritability is higher, but can be successfully ameliorated by using paracetamol in the first 24 hours. So as I mentioned, the immunogenicity and safety with co-administered vaccines has been established, although, as I mentioned, when given with pertussis containing other vaccines, the rate of fever is higher when given with Bexsero. So this is the tolerability, and as you can see in infants, it's a relatively reactogenic vaccine with changes in eating habits, sleepiness, irritability, and unusual crying and fever. Very well described, but no increase in febrile seizures. In real-world use, this has been validated in the UK, as well as Canada and more recently Australia, with no real additional concerns raised. So in terms of co-administration in infants and toddlers, this is the data that you can see. There's a higher rate of fever, not incredibly high fever when there's co-administration, but in mild to moderate fever, there is an increased rate. And as a result, prophylactic paracetamol with 3 doses over the first 24 hours appears to successfully manage this. And so ideally take the first dose of paracetamol at the same time or 30 minutes before or as soon as you can after vaccination, and then 2 additional doses at 6-hour intervals. And if the baby's sleeping happily, we would not recommend waking the baby up to give a dose. We would just recommend giving the dose when the baby wakes up. Oh, and I should mention, using paracetamol does not change the immune response to the vaccine. So this is advice regarding how to give multiple vaccine injections in infants under the age of 12 months. You can give 2 vaccines in the same thigh as long as they're separated by 2.5 centimeters or an inch. But if there's a third vaccination, use the other thigh. So in terms of the safety considerations for Bexsero, it's, as with all vaccines, contraindicated if you've got a known hypersensitivity to any of the components of the vaccine. It's important to note that because we're not using the capsular polysaccharide and proteins that the vaccine does use is more variable, Bexsero covers around about 75% of the circulating MenB strains in Australia. If someone has a severe febrile illness, we would not recommend giving the vaccine and postpone until the fever's gone away. And in people with impaired immune response, you may get a reduced antibody response, but typically we would still recommend giving the vaccination. So in terms of effectiveness, as I mentioned, it covers about 75% of the MenB vaccines we have in Australia. The effectiveness data is about 71% effective against all-cause meningococcal B invasive meningococcal disease from Spanish data post-implementation, and data from Alan Marshall's group in South Australia after the first 3 years at a population level. There was a 63% reduction in infant invasive meningococcal disease and a 79% reduction in IMD seen in adolescents. So with a effectiveness compared to no vaccination of 91% in infants and 83% in adolescents. And really encouraging, they noted some protection against gonorrhea in the adolescent population. And they've gone on to study that in more detail, and we're looking forward to those Australian results, but we do have similarly encouraging results from elsewhere. And it does appear that the similarities between the outer membrane vesicles in the MenB vaccine also confer some protection against gonorrhea in adolescents and young adults, with protection between 40 to 50% observed in a number of studies, which is substantially exciting. So in summary, Bexsero is the only MenB vaccine indicated from 2 months and above. Real-world data shows no significant safety concerns when Bexsero is co-administered with other routine pediatric vaccines, although there is more systemic reactogenicity in infants, especially fever, but that can be managed with prophylactic paracetamol. So we know that awareness around MenB varies, and it's certainly worth discussing with your families if they're interested in this vaccine. It's important that we make aware that the vaccine is available, but also that we endeavour to find a way to make this vaccine available for the NIP. And it's complicated because it's incredibly hard to make a vaccine against a very rare disease cost effective, notwithstanding the fact that this appears to be an effective and safe vaccine. So, in conclusion, we've seen a global reduction in both the incidence and mortality due to invasive meningococcal disease due to the implementation of vaccines both in high and critically in low and middle income countries, in particular the sub-Saharan African belt. And that is particularly the Menafrivac vaccine, now called MEN5, including serogroup X. Around the world, overwhelmingly Group B dominates and that includes after COVID-19 pandemic re-emergence. We've seen the emergence of serogroup X that appears to have been successfully managed with the incorporation of that into the African vaccine. And ACWY vaccines remain highly effective. MenB vaccine is effective and available, but sadly not available in some states and not available in the NIP for healthy individuals. Thank you very much. Just stop sharing.
Jim, many thanks for a comprehensive overview covering the invasive meningococcal disease, looking at the clinical features and the epidemiology in great detail, and covering the vaccines in regard to their recommendations, effectiveness, schedules, funding, which we will talk about, I think, and the practical aspects around administration and co-administration. Jim, we do have several questions which have been entered during the session, and I would like to ask those questions, but I might start with one. There's been some lively confusion in the chat about the issue of the primary course and boosters in infants and children, and some concerns that there's conflicting advice in the immunisation handbook and elsewhere. And I don't know, Jim, if you're able to give some insight into how we address boosters with MenB.
Sure. So there's, in general, if you're getting a dose in the first 2 years of life, we recommend 2 doses, and the recommendation is that they're at least 2 months apart. Now, as you've seen with the risk from MenB, if you have the luxury of getting in as early as possible, we'd recommend starting at 6 weeks or 2 months of age. And getting your second dose early, because the highest risk period appears to start between 3 and 6 months of age. Irrespective of when you have it in the first year of life, we recommend a booster dose, and in other words, a third dose after 12 months of age, or as you get older, more than 12 months after the primary series. The booster doses after that, we don't know. We think that most protection against meningococcal disease relates to circulating antibody, not to immune memory per se. So we assume that boosters may be required down the track, noting that the two highest risk periods are quite two defined periods, early in life and then in the adolescent period. Now, as you saw from the epidemiology data, yes, you can get meningococcal disease at any age, but those two highest periods are covered by the routine vaccination recommendations.
Great, thank you, Jim. I've got two linked questions involving the 15 to 19 year age group. The first question is, do we know the vaccination coverage rates for the states and territory and Northern Territory that provide that under their programs? What proportion of 15 to 19-year-olds are getting vaccinated?
It's a good question. I'm really just seeing the South Australian data, so my apologies. I'm not across the Queensland and Northern Territory data, noting that historically Northern Territory have a really impressive vaccine delivery system. I think my understanding of the South Australian data is that they were getting coverage of up to about 79 to 83% in South Australia, but I haven't seen the recent data. I apologise.
And the second question is for the jurisdictions which do not provide the funded MenB vaccine. So that's the majority of 15 to 19-year-olds in Australia. What can we do about them? What steps can we do?
Look, I think as is already happening, there are both patient groups and many health professional groups advocating for introduction of the vaccine. The real kicker with this vaccine is this, because this was such a damn hard bug to produce a vaccine against, it was a real revolution. It was the first vaccine that was developed by reverse vaccinology. And so Rino Rapoli, when he was based in Siena, came up with the idea that we'll go to the bacterial genome and analyze a genome and work out from the genetic sequences what might be important in terms of providing immunity, and then we'll test that. And it's a vaccine like no other because it's the very first reverse vaccinology designed vaccine. But it's hard to make it a really cheap vaccine. And it's not ludicrously expensive compared to some other vaccines, but because of that, trying to work that into a cost effectiveness decision making, that all of our medicines and vaccines in Australia are decided on for the NIP is really difficult. And they and the PBAC have been trying for over a decade now. In terms of the jurisdictions, they face the same dilemma because some jurisdictions have better funded than others in terms of their economies, but it's still a significant recurring expense that they're not confident that the NIP will take over. So is there a need for it? Absolutely. Is it a worthwhile vaccine? Yes, it is. Is it a cost-effective vaccine on the way we traditionally calculate cost effectiveness? No, at the moment it's not.
Thank you, Jim. And you've answered about 4 questions in one go because there were questions as why is Bexsero not funded Australia-wide? And I think you've addressed that that's an issue that's been looked at over many, many years and has yet to be resolved. Perhaps looking to the future, pentavalent combination vaccine. What do we know about current trials, current safety data, and the potential for this coming to Australia?
I think those data are encouraging, and I don't think we're that far off seeing it come to Australia. And that'll be fascinating as to how it's dealt with.
Yeah. And to keep coming back to funding, because it's an important issue, we have a question as, do you know how much a dose of Bexsero of meningococcal B vaccine costs? How much do we, when patients come and ask about it and parents come and ask, what do we tell them that they're going to be charged when they go and pay for it?
I think depending on the pharmacy costs, etc., the costs vary from about $135 to about $160. Oh, there you go. Someone's also put in a cost there. Thank you.
So, thank you. Yeah. Moving to an older age group, I've got a question about the 30 to 50-year-old age group. Can meningococcal B vaccine be given to adults in that 30 to 50 age group?
Absolutely. So we already give it to adults in the 30 to 50-year-old age group who are at risk. So for uh, obviously for travellers, or the MenB is not specifically recommended for the harsh, but people in at-risk occupations or people with underlying risk factors, we routinely give MenB vaccine to those groups. It's important to note that although meningococcal disease occurs in that age group, if you don't have any risk factors, the risk is incredibly low, but it won't stop the vaccine from working and being a safe vaccine to have.
Mhm. Going back in time a little bit, you showed a chart with meningococcal B incidence declining over the sort of 2005 to 2019, which predates the meningococcal B vaccine introduction. Do we have an explanation of why that might have happened?
I think we have many theories. I don't think we have a known explanation.
Hmm.
For the same reason that we don't really know why Group C meningococcal disease was rising from the late 80s and into the 90s, apart from it just was. I'm not aware of any satisfactory explanation. So
Hmm.
I think there's still a lot we need to understand about meningococcal epidemiology and transmission, and dynamics. And I can guarantee you I'm not the person to know it.
Cool. Mhm. And changing age groups are coming back to the adolescents again. And the question is, given the waning immunity and also the cross protection of meningococcal B vaccine with potentially with gonorrheal disease, should we be boosting all adolescents who had a primary course as a infant or young child?
I think, as I implied, we're still waiting
Yeah.
on the boost because the vaccine's still too young to for that the babies to have got up to the adolescent age group. My best guess is yes, we should be.
Yep. Mhm. And again, staying with the adolescents seems to be the topic of interest. Declining vaccine coverage rate in the adolescents. Are we seeing any changes in IMD epidemiology as a result of that?
I don't think we are at the moment, but it's probably a lagging indicator given it's such a rare disease and the declines are relatively recent. But and also we can't explain some of the changes in meningococcal as we've just described. I think the that's a serious concern for meningococcus, but I think it's a much greater concern for things like HPV and measles vaccination in particular.
Mm. We indicated that IMD is fortunately rare, but if there is natural infection, does this provide protection against future infection? So,
Yeah, it does. So what we don't know is we know that not all infections produce an immune response. But what we also know from that Vietnam study is that folk that already had pre-existing immunity and they not had pre-existing disease and the
Mm,
vaccine didn't exist were protected.
yeah,
So some infections produce protective immunity. We don't think all infections, and we don't know which ones do and which ones don't.
yeah. Different question, and this is regarding breastfeeding. What, if any, is the protective effect against invasive meningococcal disease from breastfeeding?
I, I think the answer is we genuinely don't know. The logic dictates there's probably some protection, but because it's such a rare disease, again, a good thing, but that makes it almost impossible to work out is breastfeeding and any does it offer any additional protection? Because the number of cases is so rare, you'd need a study of millions and millions to be able to tell, and no one's ever done that study.
Yeah. Another one of these clarification issues around the primary course and around the boosters. I probably should be able to answer it, and I can't. Can we not give the first dose of Bexsero when the infants attend for their 6-week vaccinations?
Yeah, you can.
Yeah, thank you. Right.
I don't know. So I think it's licensed from 2 months, but it's used from 6 weeks of age in the UK.
Yeah. So thank you for that clarification. And we've got a comment from one of the members of the audience saying that they've been advised that paracetamol should be given strictly 6 hourly. I think you'd mentioned that if you've got a sleeping happy child, then let sleeping babies lie. What about this? I'm not sure what the origin of the instruction for strictly 6 hours is, but what do you think about that?
I think the strictly 6 hourly advice may come from that's how they did it in the clinical trials.
Right.
I think if you want to wake your baby for it, by all means, you're welcome to. My personal practice and advice would be I would give it to the baby as soon as they wake up, and I would not wake a baby for them to express their displeasure to me.
Exactly. Yeah. Yes, that makes sense. Well, in terms of time, we're approaching the end of the session, and in fact, we've addressed most of the questions that are, in fact, virtually all of the questions. Several covered the same issues, and we've answered really everything. So perhaps I will just ask Jim before we close. Do you have any further comments that you'd like to add to what we've covered in the session so far?
No, I think this is an important topic and one that scares frontline clinicians because it's such a difficult disease to recognize. So, at the risk of giving it a second plug, Alan Jung's article back in 2003 is worth reading because it underlines how difficult it is recognizing. The fact that we've got excellent to very good vaccines for all strains is really exciting from when I started my training when there were no vaccines. It's been a revolution and we're in an exciting period. We're still facing hurdles as to how do we implement it and afford it, but we're in a better place than we were a few decades ago.
Thank you very much, Jim. So you've presented, to say, the realities of IMD and the vaccines, the challenges that are facing us as well, and your insights have been exceptionally helpful for us. So many thanks, Jim. So thank you, Jim, and to you, our audience, for your engagement and for your questions, which have been very important for the webinar. The next webinar is on HPV and will be presented by Angela Newbound, and that's in 2 weeks' time on Wednesday, the 11th of March. And you can register on the Immunisation Coalition website from now. There will be a very short survey which will be sent to your registered email address, and we really do appreciate your feedback, please. So that's it from me. Thank you for your participation, and I hope to see you again in 2 weeks. Stay safe and good evening.
Thanks very much.
Okay.